welcome everybody. I expect we'll have a few more join on as we go. There's a few people in the room here as well. But like I said, I expect hopefully more will join. So I'm Brian Buchanan. I'm an intensivist at University of Alberta Hospital. Also, obviously, have a big interest in critical care ultrasound and also clinical teaching in ultrasound. And we'll talk about cardiac source of embolism. So I thought this was a good topic to cover because it actually comes up periodically in our practice, especially in general ICU, but in neuro ICU as well. And so I thought we'd talk about some, let's go back here. Key manifestations of cardiac embolism. We'll compare and contrast different cardiac etiologies, and then key echo features that are associated with an elevated risk of embolism. Because of course, not all that wiggles will embolize. This is pulled from case reports, clinical guidelines, systematic reviews, personal and clinical experience. And I've tried to make this as case-based as possible. That way, it's just me not droning on and on about cardiac embolism. There are some key documents. This one at the top here, it's getting a bit long in the tooth now. It's published 2016, but actually it's a really, really good article. And for those who want to read more, I would strongly encourage you to take a look at it. It does a really good job, like most of the AAC guidelines, in breaking down and providing really nice, succinct explanations of the different pathologies. And then the next one is from the Journal of Cardiovascular Cardiography, Evolving Role and Use of Echo, a bit shorter and a bit easier to read. And then finally, the European guidelines that are done in conjunction with the Canadian Society of Echo, which again is another really nice set of recommendations that's a little more recent. So these are really complementary documents that you can take a look at. So I think, needless to say, there is a huge variation in cardiac sources of embolism. We're not going to go through each one of these like kind of like one by one, because I feel like that would just cause intense boredom. So we're going to do it case-based in cases that are actually real. None of these have been manufactured, but of course, some of the details have been obscured for the purposes of anonymity. So this first one, case one, this is a 64-year-old female with history of atrial fibrillation. She presents with abdominal pain and hypotension, and no surprise to anybody, she is diagnosed with mesenteric ischemia from arterial clot in the SMA. Okay, so this is just showing here, there's an abrupt cessation of flow of the SMA, and basically it's bowel ischemia. Okay, just go 1 second here. This is interactive, so if you pull out your phone, go to menti.com, put in the code at the top, and you'll be able to answer a skill testing question. So, of course, the goal of this is to be interactive. Menti.com and put in that code. Okay, I will keep this moving along. People can keep joining on as they go. Okay, so what is the most likely cause for this patient's condition? LV thrombus, atrial fibrillation, low flow mesenteric arteries, or paradoxical embolism. Okay, so 75% said AFib and 25% said LV thrombus, but those are small numbers, I understand. So again, history of atrial fibrillation, abdominal pain, hypertension, diagnosed with clot in the SMA. So arterial emboli are a frequent cause of acute mesenteric ischemia. This is not a talk on acute mesenteric ischemia, but I think I just want to emphasize the point that 40–50% of these cases are most often a cardiac source. And just given the history of AFib, that makes your level of suspicion higher. Some of you may already kind of know where I'm going with this, but some common causes of why people have clots in the systemic circulation. Obviously, things like MI or infarcts, atrial tachyarrhythmias like atrial fibrillation or flutter, endocarditis, cardiomyopathies, especially when they have a significantly reduced LV function, ventricular aneurysms, and valvular disorders. Okay, so these are just some of the common causes. This is not an extensive list of causes, but and these ones here are just risk factors for mural thrombus. So thrombus that's a little more flattened out against the LV wall. Arterial embolism can also occur in setting of coronary or cerebral angiography, of course, dislodging clot. And the SMA in particular is the highest risk because that's got an oblique takeoff. Again, this is not a talk on mesenteric ischemia, but I couldn't help myself having a slight digression from the main topic. 15% occur at the origin of the SMA and 50% lodge distally. So this is a really common artery to embolize too. And again, that's why, you know, certainly a lot of the surgeons are on high alert for this because they know that obviously, even if you fix the problem, well, if they're still going to embolize more clot, then they may not actually fix the problem. And then acute onset of pain versus, say, more chronic ischemia where they have some collateralization. So this is, you know, a very much a hyperacute problem with an embolus. Next question. You highly suspect a left atrial appendage thrombus. What is the best test for this in the ICU setting? TTE, TEE, cardiac CT, or cardiac MRI? Right. So again, just like before, 75% say TE. So TE actually is the imaging modality of choice. The left atrium is directly in front of the esophagus. So when you put that TE probe down and you look in the left atrium, you have an amazing view. In fact, you have a front row seat, as I've shown here, right to the left atrium as to what's going on. The nice thing is a TE probe, it's got pretty high frequency compared to a TTE probe, so you get really good resolution, which makes it very strong in imaging the left atrium and its associated structures and the valves, for example, the mitral valve. But the left atrium can actually be multilobular or multilobar, I guess, should say, anywhere between 1 to 4 lobes. So it's actually not necessarily that straightforward. And there actually are ways to look at it that may offer higher resolution, but frankly, just aren't really done as much, particularly in the acute setting, more in the chronic setting where you have time and you're a little less worried about acute problems. TTE or just regular echo is still valuable, especially if you're looking at left-right heart function, looking at dimensions, especially left atrial dimensions, for example. There's even some growing interest in left atrial strain as a measure of left atrial emptying as a predictor of clot. So there are some kind of emerging modalities that people are really interested in. But by and large, it's definitely more structural in terms of looking at with the transthoracic because you really have less perspective in looking at left atrium. From a TTE angle, you're just further from left atrium in terms of versus a TE where you're really like, again, at the front row seat. Here's just an example of really how close you are. Okay, so on the bottom right, there's a 2D image. Okay, that is a mid-esophageal long axis, okay, or 2-chamber, and it's showing that atrial appendage. I'll point it out here. Okay, that's the atrial appendage. That's anterior portion of the heart. So that's kind of what we're looking at. And usually, if we're going to interrogate it, we'll go in zoom mode, look at it much closer to see whether or not there's anything that's interesting in there. We also look, for example, what does the valve look like? Does it look normal? Is there a lot of regurg or stenosis? Is there a lot of kind of swirling smoke in left atrium that are what we call spontaneous echocontrast, for example? Is left atrium big? These are all structural things that we look at. We also will look at what the velocity, the ejection velocity is of the atrial appendage as a predictor of thrombus risk, okay? So here, for example, this is a pretty generous left atrium. You could store another left atrium of a smaller size inside this one, like a little nesting doll of atrium. And so these are things that you look at categorically and think right out of the gates, well, maybe there's a thrombus there. Okay, and you can see different examples here of thrombi that are seen within the atrial appendage. There are lots of considerations. The appendage can be full of these kind of pectinate muscles, which have invaginations, and they can very much look like thrombi. So usually when we see thrombus in the atrial appendage, we look for other signs that there's, kind of delayed emptying of left atriums and swirling, other risk factors for left atrial appendage emptying. And of course, this happens because of blood stasis. So sinus rhythm is what protects against clots. It empties well. And then atrial dysfunction increases the risk of thrombus formation. So TE allows practitioners to detect atrial dysfunction. Like I mentioned, issues with low LA atrial appendage emptying velocities and spontaneous contrast. But again, this can be complex. So this does require certainly an upgrade in skill set to be vigilant in detecting thrombi. This is not maybe the best transmitted view, but there's a piece of thrombus there floating within this generous kind of thumb-sized atrial appendage. And here's just an example of the typical triphasic waves of the atrial appendage velocities. Okay, so this is just showing an example where those appendage velocities are certainly reduced. Once they're less than 20 centimeters per second in systole, we expect that most likely this is an elevated risk factor for atrial appendage thrombus. And then like I said, there are lots of reasons why we would use TTE versus TE. You'll hear more about this, but like, for example, when we're looking at the LV thrombus, then technically we actually favor more transthoracic because the left ventricle and the apex is frankly just closer to an apical view of transthoracic, whereas TE is really good at looking at valves, looking at left atrium, aortic atheromas, looking at the valves. And that's often because, as mentioned earlier on, it's such a high frequency. There is less tissue and bone between the left atrium and the probe in the esophagus, so it affords you much higher resolution and detail. So, as case started, it was a case of acute mesenteric ischemia with a patient with atrial fibrillation. This is a risk factor for atrial appendage clot, and this can act as a nidus flammus formation. And typically, TE is preferred. This is oftentimes the selection chosen prior to, say, cardioversion, for example. But increasingly, there is more interest in using other modalities as well, such as CT and MRI. We have Dr. Gamble in the room from cardiology, who I understand just passed his cardiology exam. Woo! Maybe I'll ask him a question, because now he's the guy. But how often are they using non-TE prior to cardioversion? Are they doing CT and MRR for atrial appendage or not often?
Probably like some weird general.
Oh, okay.
Or occasionally, sometimes you get these really challenging post-operative ones. It's so they use like metal.
Oh, I see.
The CT card.
Okay.
Occasionally, it's really great to doing it, but it's pretty rare.
Less common. That makes sense. I guess there's 3D as well, like 3D TE as well, which they could use. But even that, I guess I'm less sure how often they would use 3D.
They use amon, all of them are LV like neural thrombus, but they're worried about
neural thrombus. Yeah. Yeah.
That's not well seen on TT.
Yeah.
But it's pretty weird.
That makes sense.
Thrombus overall.
So TE is more the selected. It makes sense. It's just abundantly practical, and again, does afford you a very good view of the left atrial appendage. And again, usually you should expect to see other manifestations of atrial dysfunction besides just a thrombus. Okay, any questions on the first case? I guess to finish it off, she had a bowel resection, and then she was right as rain. And then had to coagulate it after. So she was fine. This next one, 64-year-old female with no past medical history, presents with painful, swollen left leg to emerge. She has an ultrasound performed. This is what's shown. This is going to be a bit of a digression in the ultrasound angle, but we're going to ask everybody here what you see. Now, again, just pull out your phone, put in the code at the top, and you'll have a chance to answer this skill testing question. The image is probably better on your phone than it is on the screen that I'm displaying here. Okay, so most people said non-compressible DVT. Yes, that is correct. This is non-compressible. Okay, the fact that we can see the artery begin to occlude means that you have exerted enough pressure. That would be your standard. And sometimes you see clot, especially when it's older, fresher clot or very fresh clot. It's more hypoechoic or even anechoic, so you may not see it at all. That's why the definition of DVT is really a non-compressible vein. Okay, so this lady has a swollen, painful left leg. She has a DVT, but while in the emergency department, she becomes severely short of breath, progressing to 100% high flow optiflow. Okay, well, I think we know where this is going maybe. As the team prepares to intubate the patient appears less responsive and has a dilated left pupil. Further neurological exam demonstrates dense right-sided weakness, upper extremity and lower extremity on the right side. She is intubated in the emergency department and started on vasopressors. She is sent for a chest and head CT. Okay, the chest CT shows a clear filling defect and presumed PE. And the CT shows, let's see if this will actually display here. A hyperdense MCA sign and a new established left MCA stroke. Okay, so pretty quick. This happens in very short succession. Here's the question. What is the best explanation? And that's just type it in. What happened here? And this lady had a DVT, all of a sudden went into severe respiratory failure, and then appeared to have a left MCA stroke. So what would explain this? Yeah, so this is a challenging case, and for those who are closely following along, quite a sad one. And I think we kind of have a sense of where it's going to. What is the name for this condition? Pardon me? Paradoxical embolism. Correct. Yeah, you bet. Okay, so this is the echo from this lady. Okay, she was pretty unstable when she came into ICU, to our General Sims ICU. Anyone want to take a crack at these images? Normal, right? Totally normal. Nothing going on. Nothing to see here. Flattening of the interventricular septum, I presume. Yeah, sure. Okay, is it always flat, or is it flat during certain periods? It's pretty quick, right? Like, it's pretty tacky, so it's kind of hard to say without. Okay. Pardon me? Hyperdynamic LV. Okay. Pardon me? The RV's dilated. Yeah, RV looks big. Yeah. Yeah, it's really hard to, I would say, just with the rate, to be honest, with when there's no cine function and ECG, it's really hard to say whether this is persistent, but I'd be concerned that this is persistent flattening. It's just actually maybe a bit more flat during, I think it's more during systole, to be honest, like mid to late systole, right? Regardless, it's actually it's really hard to separate volume versus pressure overload on septal movements. But given the RV dilation, given the story, my bet would be on pressure overload. And pressure overload does cause persistent flattening through systole and diastole. It's just more flat during systole. So big RV, hyperdynamic LV, okay, septal, some change in septum. Here's an apical view, which was, I will say, super challenging to get. Because the apex was actually far more, best term, more dominant than I would estimate. So it was quite challenging. Plus, she was quite unstable at this time. So we see here obviously a big dilated RV. Okay, the RA might be a bit generous too, most likely. The LV is presumably, like, it's really foreshortened here, so there's not much you can say, but most likely it's kind of normal to hyperdynamic and probably has, with some shifting of the septum, some reduction in filling and some drop in output just from interventricular dependence. And occasionally you're seeing the coronary sinus here too, which I presume is probably because of an increase in pressure. So maybe that's caused some changes in the venous pressure on the right side, most likely. The TAPSE is normal. Okay, that doesn't really help us here. And certainly there are lots of cases where the RV can be dysfunctional. A TAPSE can be normal. If you look back at this image here, we see that lateral annulus is bouncing up and down, but the overall RV shape and size doesn't really change a whole lot during systole versus diastole. And then, try to get a measurement of RVSP. There wasn't a ton of TR to measure, but we'll figure it's probably at least, the estimate is a gradient 32. This is more advanced, but, presumably it's probably at least 40 as an RVSP. Could be more, hard to know. But that, generally, if it's an acute PE, we don't see super high RVSPs. We actually see kind of the lower end. Like, we don't see RVSPs of 80 to 100 typically, because usually the ventricle hasn't had time to accommodate the increase in afterload. Okay, another skill testing question. What is the next best test? CT, transcranial Doppler, a bubble study, or should we MRI the brain? But fantastic. Yeah, bubble study. So here are some bubbles. Again, it's a pretty quick, within probably a couple of beats, it's already on the left side. So perhaps a surprise to no one here, as many kind of signaled in advance, this is most likely a PFO, or at least some discontinuity in the interatrial septum. So usually if this happens early, then we expect more intracardiac. The later it happens, like after kind of 3 to 4 cycles, we think more intrapulmonary. And then usually once you're past kind of 6 to 8 cycles, it's unclear in terms of maybe some bubbles escaped the pulmonary circulation. Although less likely. So, but anyways, this is obviously very early. I'll play it again, look and see. So very quickly those bubbles show up. This is not an ideal view by any stretch of the imagination. However, again, the patient was not doing terribly great at this point, and repositioning was not a great thing to do.
What thing again is telling me when you first see that?
So what you want to do is you want to look at when the RV gets opacified. That's when the clock starts typically. So once that RV starts to get bubbles in it, then the clock starts for counting. Okay. Yeah.
One beat.
One beat. Yeah. So if I go here, yeah, I'll just slow it down.
So the whole idea
Okay.
is that when you do agitated saline,
Okay. It's there.
normally
That's
agitated
one beat,
saline
one beat.
should always stay just on the right-hand side.
Yeah.
Right? What ends up happening is that agitated saline gets filtered out by the pulmonary circulation and the capillaries because the bubbles are too big to actually cross to the left side. So in normal instances, you should never see bubbles on the left-hand side at all. If they cross within 1 to 2 beats very quickly, it suggests an intracardiac shunt. If it's like 4 to 8 beats, it usually suggests intrapulmonary shunt because it takes longer to go to pulmonary circulation and then eventually return back to the left side.
Yeah.
And the other thing that's really notable here, guys, is that when you see the bubbles cross, which chamber does it opacify first on the left? Is it the left ventricle or the left atrium?
I thought it was atrium.
Yeah, the other.
Yeah.
And the amount of people that impressive, like
Indeed.
5 beats, it's kind of grade 1, then there's like 5 to 20, it's kind of fun, and like more than that, it's like, it's almost completely opacified.
Yeah. Yeah. If you see like one lowly bubble, like
Yeah.
sure, like maybe it's probably like a really low volume intraatrial shunt.
The other quick teaching point about this, guys, is that you can clearly see that the RV and the RA are dominant in this view.
Yeah.
So it suggests that the pressures are actually higher on that side. And what ends up happening is then you'll have right to left shunting. So if the patient had a pre-existing PFO but didn't have RV pressures that were high, generally actually left side pressures are higher. So you wouldn't get right to left shunting. You wouldn't have a positive bubble study. You'd have a negative one, but you might be able to find a PFO or an ASD just by color Doppler. But the bubble study itself would be negative, right?
Yeah.
Unless you transiently increase right-sided pressures, which we do by this thing called the Valsalva, right?
Yeah. So just to kind of revisit back to signs that suggest cardioembolic stroke. So obviously in the first case we talked about atrial fibrillation, obviously, and other end organ manifestations. Things like a striking stroke in the elderly, like a high NIH score. Previous infarctions and various arterial distributions, they say kind of multiplicity in space and time. And then signs of visceral infarcts, like wedge-shaped infarctions in the kidney or spleen, occasionally even the liver as well. And then territorial distribution, more kind of cortical and peripheral. Hyperdense MCA sign, as long as the carotid's okay. And then rapid recanalization of an occluded artery in the brain. See, these are all things that we think of, and I've certainly had my fair share of cases that I've had, new wedge infarctions in the kidneys or liver, for example, in the setting of a poorly functioning heart, where perhaps an LV thrombus was initially missed, or for example, there's just a risk of with atrial dysfunction and appendage clot. So again, just things that suggest that. In this case, I think we have more. The suggestion was that the concomitant venous and arterial sources of embolism, which is really the concerning part for a PFO. The PFOs are a remnant. They help shunt blood from the sinus venosus across the intraatrial septum. That way you don't put blood through the lungs in the babies. But they are present in 1/3 to 1/4 of adults, and they're considered normal variant. And of course, I meant to put it here as ran out of time, but we did this very large shunt study in patients with COVID, called the COVID shunt study, no surprise, where we demonstrated that actually in COVID, just like in the regular population, there's really no difference in the level of shunting, and it's kind of 1/3 to or 1/4 to 1/3 of patients will have a PFO or an ASD, mostly PFOs. And these PFOs, they are a slit-like communication between the intraatrial septum. They have the secundum, which is on the right side. They have the primum, which is on the left side. And usually this closes, but it can transiently open, particularly when you have an elevation right-sided pressures, like in a PE, for example, or if Valsalva, for example, can transiently increase the right side, and then you'll get shunting. Okay, so if take a patient who's actively shunting, and then as they get better, they may shunt less. So it's just a consideration when you're managing these patients. Here's an example actually of a patient that we had actually with COVID who came in with SATs of 50%, which were not correctable by mechanical ventilation. And sure enough, you can see that small continuous leak on color in the bottom left. This is on the roof of the intra-atrial septum, very commonplace, bit of a tunnel PFO there. You can see it leaking continuously. In fact, you can see that it's not contiguous. There's a small perforation there. Okay, that's probably not the correct term, but discontinuity. So if this opens, it will start leaking. Okay, that's the one problem with these patients. Sometimes if they're hypoxia and refractoriness to oxygen therapy with the PE may suggest they have another problem. Okay.
So one other quick teaching points for the people in the room, but maybe the people online can tell as well. So you'll notice that the intra-atrial septum is very thin and it can flap kind of back and forth between, like, depending on which the pressure is between the left atrium and the right atrium. So normally in most patients, left atrial pressure is higher than right atrial pressure. So the left atrium's at the top of the screen and the right atrium's at the bottom. So you would expect in normal circumstances that the intra-atrial septum bows into the right atrium, not into the left atrium. But in this case, the intra-atrial septum is bowing into the left atrium, which suggests the right atrial pressure is going to be higher than left atrial pressure. So it's not surprising that the PFO shunt is heading in the right to left direction, indicated by that red jet that's going through, right? Because red is towards the
probe, yeah.
Right? So
yeah, thanks, Vince.
Yeah, ways to predict what's going to happen.
I glossed over the anatomy here, but this is called the bicaval view. This is the SVC. The IVC is not well seen, but is there structurally. Right atrium, septum, left atrium. So yeah, you're seeing this here. So obviously, if this was the reverse way, you'd actually see the septum either flatten or bulge the other direction, and you'd see a shunt literally the opposite way. This is done with a TE probe, so transesophageal. It's kind of in what's called a mid-esophageal position, with the crystal aligned at 90 degrees and then rotated clockwise. So basically the beam rotates towards the right side. That way it can cut through both cava, both SVC and IVC. So yeah, this is obviously a case of peristaltic embolism. It's relatively uncommon, except in the setting of PE and VTE. So unless they have a clear elevation of right-sided pressures, you got to be careful pointing a finger at PFO, because of course, you could have a, what's the term, or premature closure. You find a PFO in a patient, you think, well, it's probably peristaltic embolism, when if there's no clear evidence that there's an elevation right side of pressures, then you got to be careful. Because of course, the prevalence of these things is actually relatively common. So things that point to kind of peristaltic embolism, young age, presence of what's called an atrial septal aneurysm, which is a really big outpouching of the septum, particularly if you see it with right-sided pressures, as we kind of saw earlier, big bowing of the septum, that can be associated with the presence of a PFO, and then a large provocable shunt with Valsalva. So an increase in right-sided pressures with bearing down can lead to opening of that PFO. And here's just an example where we discovered, so transcranial Doppler can be used for this as well, for PFO detection. In fact, some studies suggest an even higher sensitivity of TCDs for PFO. That's with a special stereotactic rig, however, that does like continuous emboli monitoring. But this is what it's showing here, is that you have your arterial waveforms, and it's actually being interrupted by these high frequency spikes. Okay, so these can tell you kind of to some extent the volume. They don't really tell you necessarily if it's cardiac or intrapulmonary, unfortunately. They can maybe tell you a little bit, because of course you can look at the systolic spikes and say, how early or late? But of course, the problem is that you don't necessarily have the full clip of when it starts. So yeah, this is just the most sensitive. But again, you may need likely will need cardiac to tell you what exactly is the problem. And TE is going to be much more sensitive for discontinuities in the atrial appendage than, say, transthoracic echo. Other embolic threats. This is a little buddy here. This is a clot in transit, which is not a very common condition. However, some papers suggest that it's like 10% or 7 to 12% of patients who have hemodynamically unstable PEs will have evidence of clot in transit. Of course, you got to look forward to find it. So it may just be a case of who actually gets an early echo, for example. This one was a bit unclear, but I think it's actually, I kind of worry that maybe it's a thrombus straddling a PFO, which is contentious in how it's managed, but certainly comes with embolic risk.
The most clots in transit I've seen is actually picked up incidentally, mostly by merge dogs.
Oh, interesting.
Yeah, because like they're the ones who are like
Yeah.
undifferentiated, almost going on. Look at the heart and they catch it.
Yeah.
Which is good for them.
Yeah, so it's not terribly well seen here, but you can see, this is kind of caught up near this intraarterial septum. It can get caught in other things, like there are funny little webs called Chiari networks as well. You can see that are remnants, which can also catch these little PE nets, if you will. But yeah, these are particularly high risk for embolism. So yeah, DVTs can lead to periodostal embolisms, presence of PFO. They're common. They can reverse. Okay, they can go back and forth. And our clue here is recent DVT, hybrid MCA. Okay, case 3, 54-year-old male, altered LOC, intubated in the emergency department, becomes more unstable, is given fluids, norepi. CTS performed urgently, demonstrates multi-territory strokes. Okay, I'm not going to go into this interpretation because for sake of time, but also it's not a neuroimaging talk. So, but you can see here there's multiple territories, and there was concern here that this was obviously a cardiac source of embolism. And then it just became kind of more unstable, was a septic shock, was pending blood cultures. So we did an echo. TE, he had poor transthoracic windows. Again, plus he was in shock. This is our first view. This is called the mid-esophageal four chamber, left atrium, left ventricle, right atrium, right ventricle. And that's the pericardium, nothing much in the pericardium. The LV function here, what do we think? Normal, abnormal? It is a bit obscured, I'll admit, so you can't see it entirely here, but I'd probably think it's more on the normal side, to be honest. Yeah. Yeah, the RV actually may be somewhat abnormal, to be honest. There's, I'll say there's less here than there is here. So this was certainly the point of concern, given the story. Okay, and again, he wasn't terribly stable. So what do we see here? It's normal, move on, right? Nothing to see here. So yeah, there's this, well, Dr. Gamble, what's your, as a cardiologist, what's your diagnosis? Here's a white blob. Technical terms, yeah. Yeah, I mean, and also he's in septic shock. So we think, well, obviously, and all things being equal, endocarditis seems like it'd be reasonable, right? It's also, it crosses the valve. It's on the ventricular side, not on the aortic side.
Bigger than 1 centimeter, so high risk for embolization.
It's big. It's pretty. It's like a satellite going back and forth, right? So
for the people online and teaching point in general, guys, is that endocarditis usually tends to stay on the low flow side of the valve. So for example, on the mitral valve, you'd expect most of the endocarditis to potentially be on the left atrial side rather than left ventricular side, just because there's low flow and it's less, it's more likely to sit there. So same thing with the aortic valve here. And then oftentimes some patients will have the valve destroyed as well. So there's sometimes regurgitation associated with it, but that's not always the case. But if there is regurgitation and you see a vegetation, highly suggestive of endocarditis, right? So, because there's other lesions that might not destroy the valve, but sit on valves, which we might get to in terms of other cases.
well, I'll skip this because I think most people already answered this. So again, this is a big lesion, okay, quite a concerning lesion. And there was quite a bit of aortic regurgitation, but there was something special in this echo, which made it different from other kinds of lesions.
Not like cusp up. Have a look at where the colors go, guys. Yeah. What extra thing is happening in terms of color? Osama, you can say it. You've already kind of mentioned it. Yeah,
It's visualizing.
There's a fistula. Yeah, good. Awesome.
Yeah, from the aorta to the right atrium. which is a known complication when you have an aortic root or aortic valve endocarditis. So this guy had fistulized. And so that was quite, obviously this was all very bad. There's nothing about this case that's redeeming at all, unfortunately, just unfortunate for the man. So basically a large fistula between the aortic root and the RA. And that kind of fits with the setting of, again, multi-territory infarcts. He eventually grew Rothia dentocariosa, which maybe the name signposts where that's from. I'll give you a hint, it's not from the foot. It's from the mouth. From dentition, actually, most likely. And it can be a particularly aggressive kind of endocarditis. The rates of systemic embolism are pretty high, okay, especially staphylococcal. But generally, embolism is 10 to 50% risk. Major criteria like vegetation, abscesses, or new dehiscence. Yeah, chaotically moving mass, I should say. But basically, it's obviously a discretely different lesion that moves independent from the valve. And it also has what Vince said about kind of which chambers it's in. Embolic risks, we know that greater than 10 millimeters higher risk, but even greater than 15. And technically, if it's greater than 30 millimeters, it's even worse. But these are all things, obviously, if it's really floating into the cavity and it's got a, small stalk, for example, then I think the risk is higher. But these are all considerations, and I've certainly had my fair share of cases where, someone's had a large mass sitting there on the left ventricular side or aortic side where you're just worried that, it could give way at any time. And what are you going to do when that happens? TTE is sensitivity of 60% for endocarditis, but that's, again, it's variable depending on the study. TE is more sensitive, but can be challenged by things like prosthetic valves, pacemakers, and TE is better for these conditions and valve, especially aortic valve abscess, for example. But again, can be slightly augmented when you have devices present that can cause a lot of artifact and shading and have a difficult time picking up new lesions. And the risk of embolism is actually highest during the first day following initiation of antibiotic therapy. Risk decreases after 2 weeks. And there are times where, there's a high index of suspicion and the initial TE is negative, and they need a repeat one. And in select cases, they may need a repeat PET. They may actually need a PET CT in the presence of a prosthetic valve, just because it's just so messy in terms of picking up new valve lesions.
PET and cardiac CT are now considered major criteria of the following those.
Oh, really? Oh, interesting. Yeah.
A improvement of modality.
Yeah.
But also because of how hard it is, especially prosthetic valves, to catch lesions on the septum or like the structural.
Yeah.
It's a substitute for TE. It counts as a major criteria.
Interesting. So Dr. Gamble here was just saying that PET CT and cardiac CT in general both count as major criteria for endocarditis because they're quite useful in the setting of prosthetic valves.
In some of the settings where we've seen potentially a patient who had endocarditis and had some regurgitation or some perforations from the valves, but the embolus itself is already gone, still have a high index of suspicion that it could have still been endocarditis, even if you don't find a veg
Totally.
valve currently.
Yeah.
That happens all the time where it's like, oh, you have like wedge infarcts in the kidney,
Totally.
like, the spleen, and then they have a foot that went ischemic, and they also had ischemic valve, and they have a stroke. Oh, but there's nothing on the heart. And we're like, okay.
Yeah, exactly.
Where else would this come from? Right?
Yeah.
Like,
A mystery embolism.
mystery embolism.
A mysterious embolism. And this is just an aside, but there's lots of reasons where there's like little fake outs on the valves. This is my particularly favorite word of Lambo's excrescences or valvular strands. It's kind of hard to see here. It'd be better with a zoom mode, but you see these little strands on the valve, most likely embryological remnants from development of the valves. These things are typically, again, they're kind of on the aortic side. They're very thin. They're very characteristic. And if you do enough transesophageal echoes, you just pick these things up all the time. Okay. For those who maybe are sharp-eyed here, this patient has a lot of SAM actually. In case you're wondering that mitral valve is being sucked into the outflow tract.
I just remember yesterday we were talking about fulcrum and sigmoid septum. You see how the septum itself is a little bit thicker, specifically at the outflow? Yeah. So.
Yeah. Yeah, so again, valvular strands are very common. These are pretty low risk of embolism, and it's rare to have an association. And the problem is like you'll find these things. Interestingly, one of the things that I just wanted to mention briefly was non-bacterial thrombotic endocarditis, often called morantic, if you're fancy. In lupus, for example, these can be in upwards of 40% of patients with lupus on screening echocardiograms. And the reason I brought this up is that these are actually can have multiple widely distributed infarcts, and versus endocarditis, for example, which may have one or two infarcts, for example. So these can be quite nasty as well, and are not, again, not infective, just some kind of autoimmune inflammatory condition that's associated with chronic disease. So again, yeah. Any additions?
No, they say like the level of questions, like I would say we almost never
Attribute that.
it's they're so small, it's very hard for trauma, especially if you've got like your coronary signs are usually so good at as the blood goes out, like they're almost designed to like cause a turbulent jetty that's very hard for anything to grab on.
I see.
On the
That makes
the
sense.
aortic side of the valve.
On the aortic side, yeah, that makes sense. Yes.
Symbols are almost always on the aortic side, not on the underside.
Yeah.
So.
Yeah. I mean, they're always there. So it's like whether you find them or not, it'd be hard to say that's the cause because they're just always there. So again, pattern multi-territory stroke, especially in space and time, heightened suspicion of cardioembolism, not cardioembolism, which is a different phenomenon, perhaps. Cardi B embolism.
Remember Cardi B lines?
That'd be a good Jeopardy question, actually. And again, systemic signs of infection, as we kind of talked about, whether they're like wedge infarcts, for example. T is more sensitive than TTE, but there is some nuance, right? As we kind of talked about, where TTE strengths are and where TE strengths are. And of course, select factors heighten the risk of embolism. Last case, case 4. Okay, this is an interesting one. So this gentleman had an anterior STEMI. Here's his initial ECG. Well, this was like around the cath time. So it's an ugly one and a concerning one, and has some AFib kind of on and off during his initial CICU state. So goes to the cath lab, gets a drug-eluting stent to his LAD, and convalesces in CICU. Everything is hunky-dory, except day 2 post-admission. He has the acute onset of right-sided weakness, but actually that's not true, because actually initially it was left arm drift, which 10 minutes later became right-sided weakness with progressive dysarthria and global dysphagia. Oh, sorry. I'm just trying to get this thing to play, but it doesn't want to play. Okay. He is transferred out to neurology when he appears stable. This is the initial CT. Now, one detail that I should have mentioned at the start was actually this guy's had brain radiation in the past, and so his CT wasn't exactly normal. And what was reported was a small intraparenchymal hemorrhage measuring 9/6 in the anterior right insula. So that was, what was initially detected, and there was a follow-up CTA which did not show any cause. And so it actually wasn't overall that well explained. And they had ordered an MRI, but of course it didn't happen like that. So it took some time to get it done. In the meantime, he, had ongoing stroke symptoms, but hemodynamically he got better, and then was sent out to neurology essentially on post-admission day 7. As part of workup day 3, he had an echo done, obviously. This was, I think, just in and around the time he had stroke symptoms, and showed a depressed LV function. We can see here that wall. Which wall is that, everybody? Is that the anterior wall? Yeah, it's akinetic, right? Doesn't move. If we look at the person long axis, we can see here, this is the anteroseptum. There's maybe a bit of movement, although some of that is translational movement, but there's very little movement of the anteroseptum and anterior wall. So again, this is in keeping with the pattern we're hearing. LVF was estimated to be 40%, and they actually did use contrast to look for LV thrombus, and there was none. So he went out to neurology and was doing okay, as one would do with a new stroke, unfortunately, post-MI. But then post-admission day 9, so he's on the ward for a couple days, he has status, and it's repeated generalized tonic-clonic seizures. It doesn't stop, and so we're essentially, hands are tied, it's time to intubate him. So we intubate him, and we wonder, what's going on? Is this just in the setting of stroke? Although, I must admit, when I went back through the records and read this strange story about left arm drift, which progressed to right-sided weakness, I thought to myself, something here doesn't fit. So again, we see this really dysfunctional LV on a person long axis. That's the left ventricle. That's confirmed in other views, really not a well-functioning ventricle. So, that when I heard the story, that was what my mind went to. And I just had some concerns. So I did some non-conventional views that are a bit off axis. And, you could see here, this is kind of a modified 2-3. But it looks like there are two generously sized thrombi that are, hanging out, nearly kissing, essentially. So again, big anteroapical LV, and these are new thrombi. Actually, the difference in timing between echoes was like maybe a few days, I think, if I recall. No, it's more than that. It's like 5 days between the initial echo with depressed function and then this one. So I ended up taking images, putting them in the chart so I could ask cardiology to come back and just document this for posterity.
Even if it was missing before, because the LV function's still down, it can form over time.
Of course, exactly. And I think that I just wanted to make sure this was recorded. So, so acute anterior MI, major source of LV thrombus formation, kind of blood stasis plus angry necrotic myocardium. There's, kind of Virchow's triad type scenario, thrombus formation. This can happen also in dilated cardiomyopathy. This can happen in stress induced, especially with, apical variants where you have a lot of swirling in the apex. And then again, severe LV systolic function, complicating heart disease. In one case review, 80,000 patients, the incidence is not necessarily common, but most were from acute anterior MI, and the rest were a mix of dilated and stress cardiomyopathies.
Teaching point case, guys. So remember that cardiology had done a like contrast echo from before. What ends up happening is that the contrast that they give is usually some sort of proprietary name like Definity or whatever they're called. The idea is that the contrast is actually little micro emulsifications mixed in fat that are smaller than red blood cells. So what you do is you inject them, they light up the right side, but remember the agitated saline gets filtered out by the lungs. Yep. These microemulsifications are so small that they can actually pass through pulmonary capillaries and make it to the left side. So that's how you can opacify the left-hand side. The idea is that what you do is you opacify that left-hand side, you change some things on the echo to actually reduce what's called the mechanical index. So what you do is you try not to destroy these emulsifications, so that way you can opacify the LV, and you look for things in the apex as seen before. The thing in non-cardiology world is that we don't like the affinity contrast, or some of this stuff costs like $100 a pop. So what we typically do on the non-cardiology side is we use what's called poor man's contrast. So as Brian had already mentioned before, in a transthoracic echo, you can actually see the LV apex fairly well, because when you do an apical view, the first thing that's encountered on the apical view is the LV apex, right? So what you can do is that you can put a color box across the LV apex, turn the Nyquist limit down all the way down to low flows, and see whether or not color completely opacifies the LV. If the LV apex stops and there's no color flow going into it, something must be preventing the color flow from going into the LV apex. And the most likely thing is some sort of mass or thrombus, or not veggie, maybe not in this case, but like something's preventing that, right? It's the same thing when you look at DVTs and you try to compress. If the compression does not allow the walls to come together, something's preventing the walls from coming together. So same principle.
And then here too, you can, just taking a view where you decrease the depth. So say you go to, 5 centimeters, for example, or 8 centimeters, where you're just focusing primarily on the LV, can give you just better resolution. So here, these are a bit deeper, but if you reduce the depth, you might get a better quality image. And also if you narrow the sector width as well, it can help with your resolution and frame rate.
How long do you have a risk of developing an LV thrombus?
Well, I haven't done cardiology in a long time.
It could be once you have it, you're gonna have a risk your entire life.
And assuming that the LV function doesn't get better over time, if it stays 20%, then yeah, lifetime.
Like sometimes after you get past, your LV might come back, and so you're not gonna get the apex is particularly vulnerable just because the how like the flow dynamics there. But if you develop an anchor in your apex, like you're gonna be high risk for your entire life.
It's basically lifelong Takasubo. Like that's sitting there, just like it's gonna be there.
Depending on the morphology, sometimes you're just gonna say lines coagulation your entire life, depending on what's sitting, like how if they have thrombus there before already.
And some of those patients, because they get cath and they have a stent in, they're on aspirin, they're on some sort of dual antiplatelet, and they're on warfarin or
Totally.
chemicals, right?
So long as we did like the first year, put them on like a DOAC plus Plavix and then drop the Plavix and just keep on the anticoagulation.
So other things, so obviously echodense mass, it's next to next to a dysfunctional segment. If it's not, there's a problem. Okay, that would be very unusual. Okay, maybe you're confusing a papillary muscle. Just kidding. But usually they should be next to an abnormal functioning wall. If it's not, then there would be a concern for something else. Usually distinct margin between the LV wall and the cavity. Different ways to think of these LV thrombus. They can be protuberant, which say protruded to the cavity. They can be mural, kind of smeared. Okay, which are more challenging to delineate. Okay, and that's where sometimes they'll use more advanced modalities than echo to delineate thrombi from the wall. And the sensitivity is for TTE is anywhere between 60 to 100%. Again, it depends though in terms of quality of the echo. For example, use of contrast, as Dr. Lau mentioned. So contrast fills the LV cavity and can enhance the visibility of the endocardial border. Late gadolinium can be used. That's kind of the most sensitive method for cardiac MRI. But again, you have to be in a state where you get an MRI. And then your embolic risk increases with greater number and change of morphology of the emboli. So that case, again, was about LV thrombus and kind of the risk factors, detection, for example, more advanced techniques, and what increases the risk of embolus. So we talked about key manifestations of cardiac embolism. We talked about cardiac etiologies and echo features, which increase the risk. We covered left atrial thrombus, peridoxical embolism, infective endocarditis, and LV thrombus. And we talked about what kind of manifestations will suggest that there is a cardiac source of embolism. We talked about the strengths of TTE and TE as being complementary, but some having more select indications, for example. TE for left atrial thrombus. In other cues, for example, a dilated left atrium, spontaneous contrast with a generously sized appendage may suggest that there's a thrombus or risk factors for a thrombus, LV dysfunction and LV thrombus, and RV dilation and peridoxical embolism. Again, I did not cover an extensive list of things. Other things that are often talked about are cardiac masses like tumors, as particularly atrial myxomas, papillary fibroblastomas. There's obviously some aortic valve disease and prosthetic valves and intracranial devices that I didn't cover as well. But again, this article is fantastic to look at in terms of a comprehensive review. Thanks for attending. I appreciate everybody's support. Hope you enjoyed that.